Thank you for joining us. My name is Jenny Pagel-Guile, and I am the Executive Director of the National Pancreas Foundation. Our mission is to provide hope for all of those suffering from pancreas disease through funding cutting-edge research, providing support and education, and advocating for better services and access to care. Some of the impact of the National Pancreas Foundation is awarding over 5 million grants to up-and-coming researchers to keep them in the pancreas field and moving care and treatment forward. We've endorsed over 180 centers of excellence across the country, from cancer, pancreatitis, and pediatric, recognizing that there are needs for all of our patients and, again, elevating the highest level of care. We also provide a variety of programs to volunteers, care providers, and medical professionals as well. There are many ways that you can be involved in the Pancreas Foundation, as well as several resources available online and on demand. We have the animated patient that provides detailed information about the diagnosis as well as the pancreas itself. We co-sponsor Camp Hope with Rebecca's Wish, our first pediatric pancreatitis camp in the country, and we provide nutrition support through our cookbook services and online webinars. All of this information can be found on our website, as well as a listing of all of our active centers of excellence. Across the country, we have over 30 chapters. These are volunteers and individuals who provide support to each other. They also provide grassroots efforts at tabling at local health fairs, providing fundraising support and education. They also sit in on advocacy calls at the local and national level. We would love to have you join us if you are able, or you can start a chapter in your community. Reach out to our staff if you would like to receive more information. Again, we have a full calendar of events, virtual and in person, on our website. We have an assortment of galas across the country. We have patient education events coming up in person, as well as medical professional events. And again, all of our webinars are available on demand online. The best way to stay up to date is to subscribe to our monthly newsletter. We also are on a variety of social media, so make sure that you follow us and share with your community and peers. We would love to have you join us. Now I would like to introduce our next speaker. Our moderator for this webinar, Pancreatic Cancer Surgery Essentials from Decision to Recovery, is moderated by Tyler Rice. Tyler is a scientific writer and program manager at UNC Lindbergh Pancreatic Cancer Center of Excellence.
Thank you for the warm introduction, Jenny. Hello, my name is Tyler Rice. I'm here today on behalf of the Pancreatic Cancer Center of Excellence at the UNC Lineberger Comprehensive Cancer Center in Chapel Hill, North Carolina. I'm pleased to have with me this morning a few members of our surgical oncology team, Doctors H.J. Kim, Liz Gleason, and Bobby Torpey. We're going to walk through some common questions and concerns that we hear in our clinics about surgery for pancreatic cancer. Pancreatic cancer often carries a daunting diagnosis, and the prospects for surgery can feel overwhelming. So we hope this conversation will give patients and their loved ones some clarity and practical insight that will help them feel more empowered as they consider or prepare for a surgical procedure. I'd like to begin by talking about the various types of surgery a patient with pancreatic cancer might face, depending on their diagnosis. I'll address the first question to HJ, but anyone can feel free to jump in as we move through the questions. Let's start by discussing what surgical options are available to patients with pancreatic cancer. HA, could you give us a quick overview, maybe touching on the potentially curative versus palliative?
Sure. Obviously, this is a complicated topic, but one that patients are always interested in discussing when they come to see us in surgical oncology. First and foremost, I think most of us, when we see patients, consider the curative options for pancreatic cancer, and a lot of it is dependent on the location of the tumor. So most people hear about an operation called the Whipple operation, which is formally known as pancreatoduodenectomy, and that requires removal of the stomach, the duodenum, the head of the pancreas, and part of the bile ducts. And often this is the operation that most people think of, but obviously this is not an operation that we would do if somebody had a cancer in the distal pancreas, because that requires a different operation, which can be done either minimally invasive or in an open fashion. That's a distal pancreatectomy and splenectomy. There are lots of different palliative operations we can do. There's also many complicated central resections that we can do, which UNC is able to offer in all of its forms. But in large part are the two major operations that we do, a Whipple operation and a distal pancreatectomy.
How do you decide if a patient is a good candidate for surgery and select their particular type of surgery?
I can chime in on that one. Like Dr. Kim said, we offer patients either the Whipple or a distal pancreatectomy most commonly, and that's determined based on the location of the tumor. So tumors that are in the head of the pancreas, we typically offer a Whipple procedure, which does require removing the distal portion of the stomach, the entire duodenum, which is the first portion of the small intestine, the head of the pancreas, and the bile duct. And most people don't realize that the gallbladder has to go as well. And so that's the Whipple procedure, which also involves the reconstruction of the organs so that patients can eat and drink normally. But if the tumor is in the tail of the pancreas, then we do what's called a distal pancreatectomy. And that does include, for both procedures, we have to remove the lymph nodes that are in the area. And so with the distal pancreatectomy, those lymph nodes also are going to include the spleen, the lymph nodes that are along the vessels and then the spleen. And so for patients who have a distal pancreatectomy, they will require what's called splenectomy vaccines to protect them against encapsulated organisms or bacteria. I typically tell my patients in clinic that your spleen doesn't really do a lot for you in terms of protecting you from COVID and flu, but it does a lot in terms of protecting you from meningococcal bacteria, pneumococcal bacteria, and a bacteria called Haemophilus influenza, not to be confused with the viral influenza. And so if you are undergoing a distal pancreatectomy because your tumor's in the tail of the pancreas, that will be part of the discussion in clinic.
I just want to chime in and say that remember the majority of the patients that get pancreatic cancer are often are detected later in life. So we're in large part seeing patients that are in their 60s, 70s, and 80s. So when we're talking about selecting these patients, and I think you asked about sort of how do we pick the patients that can be qualified for surgery. It's in large part based on sort of their functional ability prior to the operations and their ability to tolerate fairly extensive chemotherapy as well as a major surgical procedure. And we often have to see them in person so that we can assess how they are doing from all of their other comorbid illnesses as well as their functional ability at baseline.
That actually leads me into my next question. If a patient is receiving another form of treatment, how do you decide when or whether to schedule surgery in alignment with that treatment?
Yeah, so we work very closely with medical oncologists as well as, in some instances, radiation oncologists. So it's very much a team approach. Here at UNC, we definitely believe in trying to give patients their chemotherapy before the operation because chemotherapy is hard to tolerate. And it can be more challenging to do that when you're also recovering from a surgery. So throughout the chemotherapy process, we're constantly communicating with the medical oncologist to see how the patient's doing, to get restaging scans to see how the tumor is responding to the treatment, and then really working as a team to decide when the best time to proceed to the operating room is.
I think this is a difficult concept for many patients to really understand. I think in large part, many patients come in with the bias, oh my goodness, I've been diagnosed with pancreas cancer and I want it out. And they really, when they come to see a surgeon, their initial reaction is that they want to proceed to an operation immediately. We've in large part adopted a strategy called neoadjuvant chemotherapy prior to surgery. And that's driven by a couple of major reasons. One, as I've stated earlier, these are fairly elderly patients, and sometimes they have a lot of other medical issues. And trying to get somebody through this big operation as well as 6 months of chemotherapy is really daunting. And the studies showed that half of them actually don't receive the chemotherapy if we give the chemotherapy after surgery. And we know that surgery and chemotherapy are both required for optimal outcomes. And so that's why we've slowly adopted an approach where we try to give as much of the chemotherapy up front. It also has some lot of theoretical advantages in that we can see what the effect of the chemotherapy is while the tumor is still visible on imaging. And so in large part, that's why because we have such a great working relationships with the medical oncologists and radiation oncologists at UNC in a very sort of multidisciplinary setting, we try to do as much of that therapy up front because we know that it doesn't impact the surgical outcomes.
Do any of you know how many procedures we perform at UNC per year for pancreatic cancer?
So if we look at it sort of in aggregate, the numbers have been fairly consistent, and it's fairly consistent for most institutions in North Carolina. So we do roughly about 75 to 100 pancreatic resections per year. And I would say about 2/3 of that number is for cancer itself, and the other third is for other diseases of the pancreas and cancers that aren't typically thought of as pancreatic cancers, such as neuroendocrine tumors and solid pseudopapillary tumors of the pancreas.
Okay, and then regarding preparation for surgery, is a physical prehabilitation program recommended before surgery?
It's a great question. So I think it depends on where a patient is starting from. Unfortunately, we do get some younger patients diagnosed with cancers of the pancreas that need to be removed. Typically, those patients are physically more fit. And so a physical prehabilitation program may not be necessary for that population. But cancer in general is typically diagnosed at later years of life. And so patients often are surprised by it. They haven't been physically exercising in preparation for a major operation. And so for patients who, they are not in a physically fit state, I always recommend that my patients at least start, my patients who are not already, going for long walks, adding a block each day or a mile each day, depending on where they're at, in preparation for surgery, because we know that the stronger a patient is going into surgery, the faster they will recover. And also the more improved nutrition a patient has, right? So the better they're eating, the better quality foods that they're eating, we also know that the faster they will heal, because nutrition is a critical component of healing. So not smoking, exercise, and making sure that patients are eating high quality fruits and vegetables and good and high quality protein are the best ways that a patient can prepare themselves.
I think this is the one also sort of unspoken advantage of doing the chemotherapy up front. Because in the past, we used to see a patient and we used to whisk them off to surgery. And sometimes they were in fairly debilitated states because of the illness and how they led to the diagnosis. But now with the approach of giving chemotherapy up front, we have anywhere from 4 to 6 months to really push the exercise regimen, just like Dr. Gleason said, and to push optimal nutritional supplementation. We try to have them meet with our nutritionists as well as our outpatient physical therapists to try to optimize their exercise capacity prior to surgery.
If they're advised to do a surgery or a rehab plan prior to surgery, how long would you say on average you would advise them to do it? Is it in a couple weeks ahead of time, or is it pretty well in advance?
I think if we have the advantage of the luxury of having months of chemotherapy, I would encourage all patients to start now. I think the diagnosis of a cancer is a great opportunity. It's scary, but we can control what we can control, and exercise and nutrition are things that we can control. And so I would encourage all patients to start now if that's when they get the diagnosis and that's something it's about to happen. Or if you can start before a diagnosis of cancer, that's also very good.
Think about your parents and your grandparents, and you're asking them to get trained up for sort of a big stress to their body. How long do you think it would take them to get them ready? It's not going to happen in weeks. And so you really have to sort of have that discussion almost at the initial visit. And you have to ask them to sort of set their goals a little bit low, because you know they can't do it. If they could, they would have done it by then. So the idea is to try to set really low but attainable goals and make slow and steady progress through the whole time.
That makes a lot of sense. Moving to the actual day of surgery. So could you map out the process for tumor resection? So describe any preparations in the buildup, any physical concerns and restrictions the night before, the morning of, and what patients and caregivers should expect throughout the day from pre to post-op.
As surgeons and operating on patients with pancreatic cancer, we work very closely with the CAT scans or the radiographs that patients have leading up to surgery. That's kind of our roadmap in the operating room. So usually patients will get a high quality CAT scan before surgery in the weeks leading up to it. And then leading up to the surgery and the day of surgery, our anesthesia team is very involved with the requirements of general anesthesia. So patients routinely won't have anything to eat starting the midnight prior to surgery. And then we oftentimes will allow them to have clear liquids or even drinks with extra calories and protein before they get to the hospital. But once they arrive, they don't have anything to drink leading up to the surgery. And usually patients, these are long operations. So the Whipple procedure can take, 4 to 6 hours to 8 hours, all depending on the complexity of the case. And distal pancreatectomies tend to be a little shorter, but I tend to tell patients that, and their families, that we're going to take as much time as we need to in the operating room to keep their loved ones safe and to give their loved ones the best outcome. And it's certainly nerve-wracking to be waiting in the waiting room to get an update or to know when the case is finished. But it's often very hard for us to predict exactly how long these surgeries will take. But we take as much time as we need to keep them safe. And then really after surgery, the recovery process begins, in those first 24 hours. It's a big surgery, but the first day following surgery, we try and get patients up and out of bed, sitting in a chair, and even starting to go on short walks so they don't lose all that strength that they worked hard gaining leading up to the operation.
We're quite fortunate at UNC that we have fairly comprehensive groups that have done this on a fairly regular basis. So preoperatively, we have a great team of clinic nurses that understand this operation, know how to advise and talk to patients prior to the operation. About 20 years ago, we started what's called a ERAS pathway, which is an enhanced recovery after surgery pathway for pancreatic surgery, which involves both preoperative, intraoperative, and postoperative factors. And it's really reduced the length of stay and the readmission rates in patients with pancreatic cancer. Our anesthesiologists and our pain service groups have taken care of countless numbers of people with pancreatic cancer, and we have a specific floor that is very adept at taking care of patients in a postoperative setting, getting them out of bed, getting them through the hospitalization in as seamless process as possible.
I'm going to actually just talk a little bit about the long-term, effects of the surgery, particularly of a Whipple operation. And I always counsel my patients ahead of time that it is a major abdominal operation, and the intestines don't like to be rearranged in the fashion that we rearrange them, but unfortunately have to rearrange the intestines in order so patients can eat and drink normally after this surgery, and drain the bile duct and drain the pancreatic duct. And so it does take several months, I would say, for the intestines to adopt to this new eating, the way of eating, the way the intestines have to be coordinated to push the food down. And so I do want patients to have patience with themselves and give themselves some grace in the recovery period, because it will be generally frequent but small meals that they will be eating postoperatively for several months, most likely. But they will be able to get back to their favorite foods, even if we have to help them to get to that point by providing supplements of pancreatic enzymes that they can take by pill. And sometimes even patients may not make as much insulin as they used to, but we can help them with that, especially if they're pre-diabetic or already diabetics on medication. They may need more insulin in the postoperative phase. And so all of these things do make recovery even outside the hospital a little bit longer. And so I do always counsel patients that even once you're out of the hospital, your recovery is still ongoing for several months. But we're here for you, and UNC, we know the phone calls that patients make and the issues that they face. And so our nurses, like Dr. Kim said, are really prepared for those calls and know how to handle and likely know exactly what you're dealing with when you make those calls.
Are there common complications that patients should be aware of as they head into surgery, or because the surgery is so it's so impactful in their long-term future and their short-term future, are they aware of these things headed into it, or are they best just to address them as they arise after the fact?
It's a complicated question, and this operation is known internationally for the complexity of the operation and the complication rate. The most sort of publicized and well-known complication is the dreaded pancreatic leak, which is a disruption in the connection that we make between the remaining pancreas and the bowel. And that happens anywhere from 20 to 40%. And if you're at a institution that doesn't do a lot of this operation, then I would say the numbers are even higher. All told, I think it's pretty safe to say that very few institutions, in fact, none that I can really think of, have been able to bring the complication rate down lower than about 20 to 25%. And the readmission rate in the literature is anywhere from 30 to 50%. And so this is a complicated operation. We can sort of expect some sort of complication, especially in this patient population. And we have to be equipped to be able to not only take care of patients after the operation on a long-term basis, but in some ways work with our partners at some of their community institutions, because a lot of times it requires patients to be seen at multiple different levels by a variety of different providers.
One of the biggest benefits of being at a tertiary medical center is that we do rely on a lot of our colleagues in interventional radiology, in gastroenterology to help us manage these complications. Because like Dr. Kim said, we can't work in isolation, and these complications do happen. But we have a really great team to work together to find solutions and get patients through these complications. And the one thing that Dr. Gleason mentioned that's so important is that patients understand the limitations with eating, because that can be a big surprise to people if they think, I'm having pancreas surgery, I didn't know eating would change in the first couple of weeks after surgery, but it definitely does. And that's one of the most common complications we deal with. It's not a major complication, but it's definitely one that takes a lot of lifestyle modification.
Regarding discussing complications and side effects, are there any typical questions that patients should ask their surgeons that you would recommend ahead of time?
I don't know if I would say there's any specific questions that they should ask ahead of time. I think that if they go to a center like ours that perform these types of operations on a regular basis, I think those discussions are very extensively discussed during the perioperative and the preoperative setting. I think we have lengthy discussions about pancreatic leaks, connection problems, or what are called anastomotic issues, the issue of gastric emptying. Oftentimes patients have a really hard time with their stomach coming back to normal function. I tell patients that it really takes them 6 to 9 months to recover, because studies show that for the first 2 to 4 months, they're usually losing more weight than they're probably gaining. And the studies suggest that most patients will lose about 10% of their body weight. And that's on top of people who've already lost a significant amount of weight because of the cancer. And so that's really hard. It's not only hard on the patient, but it is hard on the patient's family. And so we do often use supplementary protein shakes, as well as in some patients, we actually put in tube feedings to supplement their nutrition. And so I think those are all the things that we have to discuss perioperatively. And so I think patients, I think that most patients, until they really do the research into the operation, won't really know what kind of questions to answer. But I would try to urge patients to make sure that they go to an institution that does this on a regular basis, so that they can discuss those types of issues with providers.
Yeah, I don't know what questions exactly to recommend that patients ask, but I also will try to anticipate the questions that they may have, or maybe if you've never had a surgery before, you wouldn't know that I would recommend that you get a epidural, for example, for pain control. You may not know that I would put an NG tube in, which is a nasogastric tube, to drain the stomach while the patient's asleep, so that they'll wake up with a tube in their nose into their stomach. And they may not know they'll wake up with a catheter in their bladder, these multiple IVs, and then of course a drain, which I place in the abdomen near the pancreatic to small intestine connection, or anastomosis that Dr. Kim was talking about, so that if it does leak, we can at least test that fluid for pancreatic enzyme, and we can know early whether there's an ongoing leak. And that way we can hopefully mitigate or prevent any worsening complication. You can just have a leak and not have a complication, a further complication from it, especially if we can control it with the drain. So it's not, the end of the world if we have a pancreatic leak. Our goal is to make sure that that leak does not lead to other complications.
Dr. Kim, earlier you mentioned many patients would prefer to just have it taken out. And I wonder if you could touch on a little bit, what are some of the reasons the patient would not be eligible for a surgery, and what would be the course going forward if that were the case?
Yeah, I think these are the discussions that are often the most difficult. So I would say that why patients don't have an operation is a complicated topic. First and foremost, I would say there's a subset of patients that don't want the operation. And I think that is a patient decision. Oftentimes, I've seen patients choose that once they learn about the operation, they say, I don't think that's an operation that I want to put myself and my family through. So patient factors are always part of the equation. But in large part, we know that for this type of cancer, for pancreatic cancer, the not having the operation has serious long-term effects. So without the operation, there aren't long-term survivors from pancreatic cancer. So we know that the operation is a critical part of the treatment process. So we have to balance, is the patient capable of undergoing this difficult operation versus what happens if the patient doesn't have an operation? I would say the things that make me the most worried are comorbid conditions that prevent a patient from just performing even the simplest daily activities. So if they can't get up and do simple things around the house on their own, they probably will not tolerate this operation very well. I also think that people that are on significant medications, and I worry the most about severe pulmonary issues as well as cardiac issues, because those are conditions that will really prevent you from having this operation, and also patients that have severe mobility issues.
So I know at UNC, and I'm sure this is true of other centers, but our team especially is extremely multidisciplinary. It takes so many different departments to make all this happen at a great success rate. Could you talk a little bit about what makes the team so multidisciplinary? How do you connect patients with groups like pain management specialists, support groups, nutritionists, and then we're also talking about the lab research we're working on. How do we tie everything in together, and what should patients know about that process?
Well, I mean, I'm happy to start. From a clinical perspective, I think you need all of those complementary teams to make a successful pancreatic program work. So things like genetics, physical therapy, an outstanding pharmacy group. We have one of the things that we're quite proud of is our cancer support programs. So they not only provide cutting edge psychiatric and family support, but we've recruited a physical medicine and rehab doctor that has a specific cancer focus to think about things like side effects from chemotherapy as well as functional abilities. But I always, when I think about our pancreas cancer program, I'm pretty proud of what we've built from a clinical perspective. And certainly that's what the patients see. And that's what the patients want to know about from a day-to-day perspective and how will it affect me. But if I really think about pancreas cancer as a disease, the impacts are going to be made at the translational science level. And that's where people like Zhenjian Ye and Channing Durr and all of our basic scientists, including Dr. Torfi, we're really going to learn more about the disease. And I think the strength of this institution is being able to take our scientific knowledge and being able to translate it directly into human clinical trials, as well as developing those studies that will hopefully transform care into the future. And I think that's what's going to make the biggest impact in the disease. Patients don't necessarily understand that right away, but I think they will as they sort of spend more and more time at our cancer center and our cancer hospital, because those are the things that really what energize all of us and keep us coming day after day to take care of these patients that are unfortunately afflicted with this cancer.
And in our clinics, we work right alongside with the medical oncologist. So if a patient's there to see their medical oncologist regarding their chemotherapy, one of the surgeons is, always available if questions come up, and vice versa. And our patients do get plugged in with oncology nurse navigators because the healthcare system is so daunting and overwhelming, especially when you're dealing with a cancer diagnosis, that the nurse navigators are invaluable for really helping them schedule appointments, schedule CAT scans, kind of know what to do next, because it's really easy to get lost in the process if you don't have people advocating for you.
On that note, returning back to the day of surgery, when we're talking about the people that our patients might encounter, are there other people on the staff? Is there anyone else that you think they should be aware of?
Yeah, I mean, I think the day typically starts, and I haven't gone through the process myself, but from what I've observed is you meet the registration team, who's very welcoming. They know they're seeing patients who are also undergoing major operations in the same surgical tower as you, right, who are just as nervous as you, and so they're great, welcoming to our patients. And then you'll meet our nurses in the perioperative area, who follow the WHO guidelines for our checklist for preoperative care, and make sure that all the the I's are dotted and the T's are crossed, to make sure we're doing safe surgery. You also in that time period will meet our acute pain team that Tyler referred to, who is fabulous. I can't speak higher about them. They can navigate different pain management options and modalities, so that we can make sure your recovery, your job is to focus on recovering and movement after surgery and not to be worried about the pain. And so we really focus on that, and our pain team is great at that. So they will do either some sort of either epidural or some sort of tap block, or quadratus block. These are different types of pain nerve relief, and then or come up with a plan with you. And then you'll meet the anesthesiologist, who will discuss the actual intubation, because it does require intubation or a tube and the breathing machine to undergo these procedures. And then in there, and this may not be the exact order, you'll meet our surgical team, which generally includes our residents, our fellows, and who will make sure, again, that all the safety checks are done and that the consents are signed and everything is squared away. And so we all discuss as well that we're on the same team. And then before you go, you roll back into the room, you meet the nursing staff who will actually be managing the equipment and all the tools that we use for surgery. Those all have to be sterilized and clean. So it's a huge ordeal. I typically tell patients that this surgery is one of the biggest we do. It's very similar to planning a wedding. We know that there could be hiccups, but we deal with them on the day of, and we generally can predict what's going to happen, and we know how to fix them. And so in general, these things always, there's always a lot of people, a lot of commotion, but we all do these procedures all the time. So you can consider us your staff for the big day. And we're used to putting on these big events, if you will. Yeah, so I think that's pretty much it. And then I always tell patients, you'll forget all the people you met, of course. As you wake up, you'll ask when we're going back to surgery. And that's our goal. Our goal is to make sure that you go off to sleep and you wake up wondering when surgery is. So.
I did want to stress that one aspect that Dr. Gleason talked about. We have several missions here at UNC. Obviously, we want to take good care of the people of the state of North Carolina. We certainly want to make an impact in this specific cancer, and we want to learn from it. We want to innovate. But I think often the mission that we often don't discuss enough is that we all have a very strong dedication to training and teaching. And so in almost every phase of their care, you will not only see the provider, but you'll also see students. So there'll be nursing students, there'll be students paired up with the anesthesiologists, there'll be residents and fellows are specific for our service. It's surgical oncology fellows. And so all of those, there'll be nurse training in the OR. And so they will see probably a lot more people than they originally expected. But I think that's what makes the place so vibrant. And I think that I always think that the more eyes on the patients, the better, and to try to see it from multiple different perspectives. And so I find that very reassuring to have multiple people looking at the patient at all times of the day.
And then I want to finish with returning to recovery and how patients move along from their operation. So these are sort of tied in together, but is there a physical rehabilitation program that's recommended for every procedure? And should patients change their eating habits and stick to a strict diet after surgery?
Yeah, so I think this goes back to it depends on where patients are starting from, and this is very personalized and tailored to each individual patient. We have people who assess the walking and the mobility of our patients in that postoperative period while you're in the hospital, which is great because if you are not making as much progress as our average postoperative patient, and we don't think that you'll be able to be mobile when you go home, then we can make plans for a physical rehabilitation program postoperatively, whether that be an inpatient acute rehab versus home physical therapy. Versus just some recommendations that our physical therapist can give you on handouts. Typically, everyone will need some handout of some kind, but we can assess all of that while the patients are in the hospital. In terms of diet and eating, it's a little bit more challenging. We've all commented on how the GI tract will take some time. We just like to make sure that patients are able to keep some food down. Obviously, if you can keep food down, then you can't go home. And then once you're home, then the progress begins with trial and error of what foods will work and what foods won't. And we do give you a guide on types of foods that typically work for most patients, typically softer foods, foods that don't have a lot of roughage, as I always use that word. Typically the GI tract after surgery doesn't like a lot of roughage, even though I cringe in recommending patients not eat roughage because it's so good for you normally, but in the early postoperative period, it is kind of hard on the GI tract. So we do have a guideline which our nurses will go through with you of what to do. But at the end of the day, it is a trial and error. You're going to have to try each food on your own slowly over time to see what works for you. And then also pushing the limits of how much you can eat each day without going overboard. I hope that answered your question, Tyler.
And that's great.
Yeah.
Yeah.
I also recommend a low-fat, low-sugar, regular diet in addition to Creon. And we spent a long time teaching patients how to take Creon, adjust their Creon dosing to what they're eating. But I agree. I think in large part, whatever they can get down is ideal, and to supplement that diet with protein shakes. So I would say that what I learned as I moved down to North Carolina is that the diet here is different than as in many southern states. There's a lot of sort of fatty and sweetened foods. And so sometimes it's difficult to maintain that diet on a regular basis. And so we try very hard to adjust to that and adjust the Creon dosing. But in large part, that's always a struggle in the postoperative setting.
All right. I think that's all the questions I have. Unless anybody else has anything they'd like to add, I think I just want to thank the NPF for having us, giving us this opportunity to discuss a really important part of taking care of people who have pancreatic cancer. The surgery is daunting, and they should know that they have a great team at a center where everyone cares deeply and is working very hard to take care of this very devastating disease. I want to thank the doctors for joining us, Robert Torphy, H.J. Kim, and Elizabeth Gleason. I appreciate your time, appreciate everything you do, and we hope everyone else has a great rest of the day. Thank you very much.